Good morning, students. Today I'll be discussing about pelvic inflammatory disease. Today we'll be seeing definition, epidemiology, protective factors, risk factors, pathology, clinical features, management, and complications in PID. So, what is PID? It is a spectrum of infection and inflammation of the upper genital tract organs. It involves uterus, fallopian tube, ovaries, pelvic peritoneum, and parametrium. Cervicitis and vulvovaginitis are not included because it is just the upper genital tract. It is caused by ascending infection from the cervicovaginal canal to contiguous pelvic structures. Depending upon the organ involved, PID may be named as endometritis if endometrium is involved, salpingitis if fallopian tubes are involved, pelvic peritonitis, tubo-ovarian abscess, or parametritis. PID incidence is increasing these days due to increase in sexually transmitted diseases. Changes in epidemiology of PID are it is shifted from inpatient to outpatient. Less severe disease is more common, more chlamydia trachomatis than Neisseria gonorrhea and other microorganisms. Incidence is 1 to 2% per year among sexually active women. 85% are sexually active females of reproductive age group. Protective factors for PID are barrier methods of contraception, steroidal contraception, monogamy, pregnancy, menopause, and vaccines such as hepatitis B and HPV. Risk factors are multiple sexual partners, menstruating teenagers, sexually active teenagers, intrauterine device users, lower socioeconomic status, previous history of PID, and absence of any contraceptive pill use. PID is usually a polymicrobial infection. Primary organisms are Neisseria gonorrhea and Chlamydia trachomatis. Other secondary organisms, aerobic will be non-hemolytic streptococci, Escherichia coli, group B streptococci, and Staphylococcus. Anaerobic organisms, bacteroid fragilitis and Peptostreptococcus. Mode of infection of pelvic inflammatory disease is mainly through continuity and contiguity. Through lymphatic and pelvic veins, through bloodstream, from adjacent infected extragenital organs. Pathophysiology of ascendant infection, cervicitis, which causes endometritis, in turn causing salpingitis or salpingo-uveitis, tubo-ovarian abscess, and finally peritonitis. That is, the infection is ascending from cervix to endometrium to fallopian tubes, then ovaries causing tubo-ovarian abscess, and finally the peritoneum. This is the process of ascending infection. Fallopian tube in acute salpingitis, fallopian tube is swollen, edematous, hyperemic with visible dilated vessels. Mucosa is edematous, infiltrated with leukocytes and plasma cells. Inflammatory exudate is discharged into lumen, mainly ampulla. Ulcerations of mucosa causes adhesions and tubal blockage. When fimbrial end is not closed, pus pours into pelvic cavity. That is a sure sign of pelvic inflammatory disease. With sealing of fimbrial end by fibrinous adhesions, the pus will start accumulating in the tubal lumen, forming abscess. With involvement of the ovary, the tubo-ovarian abscess or mass is formed entangled in the adhesions. This is the picture showing acute salpingitis. One side is the normal fallopian tube, the other is the infected fallopian tube where the pus is accumulated inside and hence the tube is swollen, and finally that place causes tubo-ovarian abscess. Acute phase of infection is followed by resolution. If infection does not cause appreciable tissue destruction, then it resolutes. But if the infection is continuing, endosalpinx is destroyed, converted into granulation tissue, pus is formed leading to tubal abscess. Tubal wall thickens, plicae adhere to distort the lumen. This is called fibrosis. Tubes and ovary adhere to adjacent organs. Hydrosalpinx is when the inflammation subsides with fimbrial end sealed and tubal epithelium is intact, secretions will start accumulating, the cornual end is open, muscle is damaged and stretched, the tube will drain into the peritoneal cavity. Flattening of the tumal plicae occur with exfoliation of the epithelium. This will cause tubo-ovarian abscess. How is the spread occurring? Through lymphatics and pelvic veins, spread of puerperial and post-abortal infections, cervicitis and exosalpingitis. This will result in peritubal and periovarian adhesions and thickened tubal wall. Through bloodstream, genital tuberculosis will occur almost always secondary to a primary focus somewhere else. The mode of spread is generally hematogenous spread. Once genital tract is colonized, granulomata containing viable tubercle bacilli will be formed. Following the development of tubercular hypersensitivity, these foci will become silent. The active growth and increase in blood supply to genital organs around menarche leads to reactivation of the disease. When the tubercle bacilli infect a host, initial reaction is polymorphonuclear exudate. Within 48 hours, this is replaced by mononuclear cells, which are sites for intracellular tubercle replication. As cellular immunity will develop, destruction of the tubercle bacilli begins, leading to cessation necrosis. Later, reactivation of the lesion will lead to classical granulomatous lesion, that is central cessation and necrosis surrounded by epithelioid cells, giant cells, monocytes and lymphocytes. What are the stages of acute PID? This is important. In stage 1, there is only acute salpingitis, no peritonitis, that is, no adhesions are formed. In stage 2, there is salpingitis with peritonitis causing purulent discharge. In stage 3, there is salpingitis with superimposed tubal occlusion or tubo-ovarian complex. In stage 4, there is ruptured tubo-ovarian abscess, and stage 5, there is tubercular salpingitis. Pathology. Pathological process is initiated primarily in the endosalpinx, gross destruction of epithelial cells, cilia and microvilli, acute inflammatory reaction causing hyperemia and edematous tissue, exfoliated cells with exudate pour into the lumen of the tube and agglutinate the mucosal folds. Abdominal ostium closed by indrawing of the edematous fimbria and inflammatory adhesions. Uterine end is also closed by congestion. Exudate is accumulated in the tube. That's why it is called hydrosalpinx. If pus is accumulated, pyosalpinx. Growth of other pyogenic organisms and anaerobic organisms will occur in this exudate, which will further cause the tissue destruction. Filmy adhesions of the tube with the surrounding structures. If the exudate will pour out through the abdominal ostium, then pelvic peritonitis causing pelvic abscess, ovarian abscess, tubo-ovarian abscess will be followed. This is the picture showing the adhesions of the tube and the inflamed fallopian tube. When the exudate pours out, it causes peritonitis, ovarian abscess and tubo-ovarian abscess. The other side, it is showing the normal fallopian tube and the ovary. Clinical features in PID: bilateral lower abdominal and pelvic pain. There will be fever and headache, irregular and excessive vaginal bleeding, abnormal vaginal discharge, nausea and vomiting, dyspareunia will be present. Pain in the lower abdomen and pelvis is the most common symptom of PID. It will occur more than 90% at initial presentation. It is bilateral. It is restricted only to lower abdomen and spreads up when general peritonitis occurs, increases on motion and sexual activity. It is severe in acute stages and dull type in chronic PID. Abdominal pain can also be associated with perihepatic inflammation and adhesions. When it is associated with these inflammation, it is known as Fitzhugh-Curtis syndrome. It occurs in 1 to 10% of patients with acute PID. So, what is Fitzhugh-Curtis syndrome? It is pain and discomfort in the right hypochondrium due to concomitant perihepatitis. May occur in 5 to 10% cases of acute salpingitis. Liver is involved due to transperitoneal or vascular dissemination of either gonococcal or chlamydal infection. In laparoscopy, we find inflamed liver capsule with classic violin string adhesions to parietal and beneath the diaphragm. What are the signs of acute PID? There is high temperature, tachycardia, tongue shows dehydration and is coated, abdomen is distended with tenderness and rigidity in the lower abdomen, per speculum finding purulent discharge from cervical canal, a torn cervix or damaged tissue is evident in the post-abortal sepsis and criminal abortion. On bimanual examination, there is cervical motion tenderness in the fornices. In later stages, tender pelvic mass is felt in lateral fornix. A pelvic abscess produces fluctuating tender swelling in POD, bulging into the posterior fornix. CDC criteria: if one or more minimum criteria are present on pelvic examination, then it is known as PID. Minimal criteria are lower abdominal tenderness, adnexial tenderness, and cervical motion tenderness. Additional criteria: temperature more than 38 degrees centigrade, mucopurulent discharge, raised C-reactive protein, elevated ESR, laboratory documentation of positive cervical infection with gonorrhea or chlamydia. This is Center for Disease Control criteria for pelvic inflammatory disease. Definitive criteria include histopathological evidence of endometritis on biopsy, transvaginal sonography or MRI showing thickened fluid-filled tubes, laparoscopic evidence of PID. Investigation: identification of organism discharged from urethra, cervical canal or tube subjected to gram stain and culture, cervical and high vaginal swab culture for both aerobic and anaerobic organism. Urethral swab culture should be done if gonorrhea is suspected. For chlamydal infection, a long wire swab tipped with calcium alginate is used to collect specimen from the tube, endocervix and urethra, and this is inoculated into McCoy cell for culture. In case of intrauterine contraceptive device users, vaginal smear should be studied for actinomycosis. Blood culture: if bacteremia sets in for Chlamydia trachomatis and Neisseria gonorrhea. In blood, investigations include mainly WBC count, erythrocyte sedimentation rate, syphilis test. Sonography: fluid-filled tube, fluid in pouch of Douglas and adnexial mass. Laparoscopy is gold standard. The findings include edema, erythema, purulent exudate, violent string-like adhesions, culdocentesis, aspiration of peritoneal fluid, and white cell count. So this is the picture found in laparoscopy in PID. These are the filmy-like adhesions which are present. Fitzhugh-Curtis syndrome: it occurs in the settling of PID when there is inflammation of liver capsule and peritoneal surfaces of anterior right upper quadrant. There is generally minimal stromal involvement. It occurs in 10% women with acute PID. Patients will have right upper quadrant pain with distinct pleuritic components, sometimes referred to right shoulder, marked tenderness in right upper quadrant on palpation. On laparoscopy, it manifests as patchy, purulent, fibrinous exudate with violent string adhesions commonly affecting anterior surface of the liver. It is associated with gonococcal and chlamydial infection. So these are the violent string-like adhesions which are found in laparoscopy in the anterior right upper quadrant. Additional tests are needed in those who are acutely ill. Symptoms are atypical, do not improve with 72 hours after empirical antibiotic therapy. Persistent pain after completing antibiotic therapy. So the imaging techniques: ultrasonography is the most useful imaging technique in PID. Thickened fluid-filled tubes, cogwheel appearance of the tube on cross section. Tubo-ovarian mass appears as a complex thick-walled multilocular cystic collection seen in adnexia, typically with thick irregular walls and septations, internal echoes and multiple fluid levels. However, USG is of limited value in mild to moderate PID. Doppler may be useful to identify areas of increased blood flow associated with inflammation. This is the ultrasonographic finding. Differential diagnosis of PID due to abdominal pain: it is appendicitis, ectopic pregnancy, endometriosis, torsion, hemorrhage or rupture ovarian cyst, diverticulitis and urinary tract infection. What are the complications of PID? Immediate complications, as we have seen, pelvic peritonitis and septicemia. Late include dyspareunia, infertility, chronic pelvic inflammation, formation of adhesions and chronic pelvic pain. Late sequel of PID include infertility. One-fourth of all the women who had acute salpingitis experience long-term complications. Most common is infertility, which occur in 20% of patients. The sequel of infection will be from patent oviduct to peritubular and periovarian adhesions, which may interfere with ovum pickup and complete tubal obstruction. Ectopic pregnancy: the chance is increased 6 to 10 folds in patients with previous episode of PID. This is due to interference with ovum transport through the tube or entrapment due to intraluminal tubal damage. Chronic pelvic pain: pain is due to adhesions surrounding the tube and ovary and hydrosalpinx. Tubo-ovarian complex, it is collection of pus within anatomical space created by adherence to adjacent organs. The incidence of adnexal abscess is 10% of women with acute PID. Mortality before antibiotic therapy, mortality rate associated is 1%. Most of the deaths are due to ruptured tubo-ovarian abscess causing ARDS due to delayed or inadequate treatment after intra-abdominal spillage of pus and bacteria. So, what are the steps in prevention? Community based approach to increase public health awareness by preventing sexually transmitted diseases with knowledge of safe sex, use of contraception, routine screening of high risk population. CDC recommendation for outpatient management of PID includes ceftriaxone 250 mg IM stat, parenteral third generation cephalosporin plus doxycycline 100 mg twice daily for 14 days with or without metronidazole 400 mg twice daily for 14 days, or cefoxitin 200 mg 2 gram IM stat plus probenecid 1 gram orally with doxycycline with or without metronidazole. Ceftriaxone has a better coverage against Neisseria gonorrhea and cefoxitin has better anaerobic coverage. Alternative oral regimens include levofloxacin 500 mg once daily or ofloxacin 400 mg twice daily for 14 days with or without metronidazole can be given if community prevalence and individual risk for gonorrhea are low. So CDC recommendation treatment regimen for parenteral therapy of acute PID. As we have seen, regimen A includes cefotitan 2 gram IV 12th hourly or cefoxitin 2 gram IV 6th hourly with doxycycline 100 mg BD or IV 12th hourly. Parenteral can be stopped 24 hours after clinical improvement and just continue doxy orally 100 mg for 14 days. Regimen B include clindamycin 900 mg IV TID with gentamicin loading dose IV or IM 2 mg per kg weight followed by maintenance 1.5 mg per kg TID. Parenteral therapy in the same way can be stopped after 24 hours and continue doxy 100 mg or clindamycin 450 mg 4 times a day for 2 weeks. Inpatient therapy includes indication for hospitalization, severe illness, suspected tubo-ovarian abscess, uncertain diagnosis, unresponsive to outpatient therapy for 48 hours, intolerance to outpatient oral antibiotic, coexisting pregnancy, HIV infected patient. Indication of surgery includes generalized peritonitis, pelvic abscess, tubo-ovarian abscess, or life-threatening infection. Management of sexual partners. According to CDC, male partners with PID should be examined, treated if they had sexual contact with the patient during the 60 days, that is 2 months preceding the patient onset of symptoms. Abstain from intercourse until therapy is completed and until they no longer have symptoms. They should be treated empirically with regimens effective against both Neisseria and chlamydia, that is doxycycline or injectable ceftriaxone with azithromycin 1 gram orally single dose. HIV-infected women with PID will have similar symptoms when compared to uninfected controls. They are more likely to develop abscess, but they respond equally to standard parenteral and oral antibiotic regimen when compared to HIV-negative women. Risk of PID associated with intrauterine device is primarily confined to first 3 weeks after insertion and it is uncommon thereafter. Evidence is insufficient to remove IUD in women with PID. Caution should be exercised if IUD remains in place and close follow-up is needed. It should be removed if there is no improvement 72 hours after starting antibiotic. First and second generation IUDs increase the risk for PID. Repeat smear and culture from the discharge after 7 days following the course of treatment. Test repeated following each menstrual cycle until it becomes negative for 3 consecutive reports when the patient is declared cured. Thank you.